So, Moni.
Oh, boy.
Tonight, we're talking a little bit about sepsis.
Yes.
But not to be confused with septic tanks. I know, it's so bad.
Oh, my.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moore Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know later.
Welcome back to Curbsiders. It's me, so it's a hospital medicine episode. I'm Dr. Mohleen Kang, joined by my ever-effervescent co-host, Dr. Meredith Trubit. How are you this evening?
Doing pretty well, Moni. How about yourself?
Living the proverbial dream. On tonight's show, we discuss sepsis with our guest, Mohleen Kang. In just a moment, Meredith will tell you a little bit more about her and the topic. But first, Meredith, will you please remind the good people in the audience what it is we do on this show?
Sure, Moni, I'd love to. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And tonight we have a fantastic conversation with our guest, Dr. Mohleen Kang. She is a pulmonary and critical care provider at Emory University. She's a physician scientist who loves data and is passionate about incorporating evidence-based practices when attending in the ICU or seeing patients in the pulmonary clinic at the Atlanta VA where she practices. So tonight we talked a lot about sepsis and all of the details of it. I think the most valuable or most interesting for us was some new information on like what to do with your fluids, as well as pressor support on the floor. So without further ado, we can go ahead and get to it.
A reminder that this and most episodes are available for free CME credit for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. Okay, we're back, and we're so excited to have Mohleen Kang here today. Before we get too into the nitty-gritty, could you just tell us a little bit about yourself and stuff, like a fun fact?
All right. Hi, everybody. Thank you for having me. My name is Mohleen Kang. I am at Emory University, and I'm a pulmonary and critical care physician. Just finished my 2 years as an attending at the Atlanta VA hospital. And fun fact, I love to bike. I purchased a Peloton during the pandemic and used it religiously. Took a little break. That has become longer, so I'm trying to get back in it. So if any of your listeners have encouraging advice, I would love to hear it.
Honestly, as a Peloton rider, what I've noticed is there's definitely certain rides where I can tell like way more physicians are on it. So it's like I'll be on there, I'll be like, oh, hospitalist, like something else or whatever. And I'm like, I found my people. And it's just really nice. And that's why I like Peloton. But they don't buy our ads or anything.
I have not found my people yet.
It'll happen with time.
Yeah. All right. Why don't we go to another question? Tell us about like just really good advice that you've gotten throughout your medical career so far.
So far, I think the best advice that I got was don't be afraid to say, I don't know. I think that has served me very well throughout my career, even as an attending. I think especially during training, we're being evaluated constantly, and there's this fear of sounding ignorant or not knowing enough and not going on your evaluation. But I find that the best I've learned during my training and even as an attending is when I've asked people to explain to me something and just plain said, I don't know this, please explain to me. And I think not only has it improved my learning, I think it has also served my patients better in the long run.
Yeah, I think I recently had this conversation with a few learners of just like, it's totally fine. In fact, I prefer it in a lot of situations. Meredith, shall we go to picks of the week?
Yeah. I feel like we might have the same one again. Well, I don't know.
I don't think so because mine is this wonderful book called Freaks, Gleeks, and Dawson's Creek by Thea Glassman. I am still a teeny bopper at heart. And it is basically a history of 7, I believe, teen soaps. It starts with The Fresh Prince of Bel-Air, and it's great. I finished the Fresh Prince chapter yesterday, and I skipped one chapter for now, My So-Called Life. Moved on to Dawson's Creek because, hashtag Joey and Pacey forever.
Dawson's Creek is where it's at. And now everyone knows exactly how old we are.
Yes, 100%. Meredith, what's your pick of the week?
So I think we'll do something that hasn't happened yet, but the reason why we're recording tonight and not tomorrow night is because Moni and I are actually going to go to the Blink-182 concert, which I'm super pumped about. I hope Moni is too, because
You've never seen them before, right?
I've never seen them live. It's like the original band. I'm really excited to see Travis Barker live, and I'm completely comfortable like going, seeing them, happen to be pregnant at the same time, and totally cool with this being the kid's first concert.
Oh, that is a great first concert. Like, he's gonna have a great story to tell that you will tell him. I have seen Blink before, so a little bit less excited just because I've seen Travis Barker live before, but it is like the main event. It's incredible what that man can do with his hands, even after having like a major plane crash and probably I think his whole spine's probably just metal at this point, titanium.
Yeah, and other fun fact, because he's with Kourtney Kardashian and we're throwing out all of these pop culture references during Picks of the Week, they're expecting a kid too, so we're pretty much like in the same boat.
It's pretty much the same. You're pretty much the same couple.
I know. So, with that,
before we get too sidetracked, Meredith, please take us to our first case from Cashlack.
Our first case, we have Miss Suarez. She is a 51-year-old female, and she had a recent traumatic left lower extremity injury, and she's admitted to the trauma team, and she's had multiple surgeries, grafts, everything to repair the leg. And per the notes, she's currently just awaiting subacute rehab, and you're the overnight nocturnist and get called for a rapid response. And on arrival to her room, the nurses inform you that she was doing well during the day shift up until they really called the rapid. But when they were doing their routine vital sign check, she had developed a new fever of 39.5, tachycardia with the rates in 110s, and blood pressure of 83/50. So, Mohleen, to kind of kick us off, what other information is really valuable for you at this point when you first arrive for that initial rapid response?
Well, knowing this history, but also in addition to that, if she has any other complaints. So somebody who's been in the hospital for that long, had a major surgery. I always think about pneumonia, which, just because they've been laying in the bed, may have some atelectasis, which may have progressed. So if she's having a cough, any shortness of breath, other things, abdominal pain, thorough review assistance, but specifically related to her leg. And because she's a recent post-op patient, this sounds like an infection, and you obviously think about patients who have surgical site infections or surgical-related infections. And lastly, if she has a Foley catheter in, some post-op patients do, then I'll also think about urinary tract infections.
Man, the Foley strikes again. I'm going to move the case along a little bit. That's really helpful because I think sometimes when you walk into the room, there's just sort of this like mass panic to do everything without really stopping and slowing down and just like talking to the patient if they're able. Sometimes mental status may not allow it, but if you can, I think talking to them and try to figure out something localizing would be helpful. And the next part of the case, your point about her recent surgery does come in handy. So she tells you that she's been feeling increasingly weak over the last 24 hours. She's been feeling feverish since shift change and really hasn't had an appetite. She doesn't have any cough, shortness of breath, dysuria, abdominal pain, nausea, vomiting, or diarrhea. But she does note ongoing pain in her left lower extremity after the surgery and has noted a development of a new rash near the anterior and lateral aspect of her upper thigh. Her physical exam is really only notable for the skin bullae over that site, the post-op site. So, I think that's helpful, but this is also a situation where I imagine a rapid response is called, or whatever that equivalent is at your hospital. And so I kind of just, before we get into like testing and stuff, want like kind of what would be helpful in like just logistically running a rapid response? Like what sorts of things are helpful?
I think depends on your institution. So how at my institution, for instance, there is a critical care nurse who always responds, which is excellent because they can help you get IV started, but also know how to give medications that you may need to give urgently. Certain ICU nurses are also able to put in IO access, or advanced practice providers who may respond may be able to do that. Depending on the institution, you may have a physician who might respond. So that's always helpful as well. Having the patient's actual nurse be there is the most helpful part, because just getting that history and figuring out what medications the patient got earlier today, and, somebody who knows where things are in the unit. And then usually having a charge nurse around or the nurse manager around, because if there's something not available right away in the room, they can call for help and they know how to mobilize stuff. So these are usually important people. And then a respiratory therapist in case there is a respiratory issue going on. That's usually also very helpful. So it really needs to be a team of people, but those are people I would say are essential.
Yeah, no, what I like is that you did list essential people, because what you did not say is every nurse on the floor needs to be present for the rapid response, which I feel is sometimes. So actually, that's the question that I think a lot of us have is like, how do we do crowd control other than like, asking people to leave? Like, what tasks and sort of things that should you just be like assigning right off the bat?
So you're right. There are many times I've walked in and there's just, a hallway full of nursing staff leading to the room and then a whole bunch of people in the room. My first job when I get in is to figure out who's who and who really needs to be there. So, I think having the ICU nurse there and maybe one or two other nurses, because we're probably doing a lot of things to the patient. So having 2 or 3 nurses there is probably sufficient for the most part. I think having somebody like a nurse manager or a charge nurse outside the door who can communicate things and call for things is helpful. And then, like I said, having the essential people in, but everybody else got to leave just so that we can rapidly assess the situation and communicate a little bit more clearly.
Yeah. And I think that's really helpful. Again, crowd control is so important because I feel like I stop having the ability to think when there's just too many people. It's just like so many people around. I guess moving, now that we have the people in the room that we need, I was kind of wondering if you could go through, obviously this patient looks sick on paper, but like what are some of the scoring systems and like that sort of thing that we use or maybe should stop using when we're trying to, really for triage purposes, I think, honestly.
Yeah, so I think I'm going to give away my age because back when I started my training, we still used the SIRS criteria a lot, which has fallen somewhat out of favor. So for just to recap, for folks who may have forgotten, SIRS is temperature greater than 38 or less than 36 degrees Celsius, heart rate greater than 90, respiratory rate greater than 20, or PaCO2 less than 32, and a white count greater than 12,000 or less than 4,000, or 10% bands on the most recent CBC. So if you had, so that's SIRS, and if you met 2 of these criteria, plus you had a source for infection, that used to be the old definition for sepsis. So SIRS criteria was not very specific, and that's why it has fallen out of favor. So as you can imagine, a lot of our patients in the hospital probably meet SIRS criteria at some point in their hospital stay. So especially post-op patient who's probably in pain. I would imagine her heart rate probably goes up and she's a little tachypnic because of that pain. So she meets 2 out of those criteria right away. Doesn't necessarily mean she has an infection because of that. So I think that's the reason it had fallen out of favor. Then came sepsis 3 definition, which was life-threatening organ dysfunction caused by dysregulated host response to an infection. And to help screen people for sepsis, people had recommended, or the definition had recommended, using QSOFA, which is the short form of the SOFA score. It's quick to use. You use altered mental status, tachypnea, and systolic blood pressure less than 100 as your criteria. And while we all started using it, it came out that it was not the most sensitive. It's very specific, but not very sensitive. So you could miss people with infection easily. There are other scoring systems like Muse and Muse, which are a little bit more involved. I know certain hospitals that use that as a dashboard for everybody in the hospital who's connected to it. And certain rapid response teams actually monitor that dashboard and respond anytime the dashboard alerts them to a patient who may be getting sicker or may need a transfer to higher level of care or just simply needs attention. Those Muse and Muse are perform a little bit better than QSOFA, and so you can use them, but they're not as quick. So you need to have your handy cell phone and an app to look at those. So I will be honest. While I would love to use Muse and Muse all the time, it's usually you don't have time to pull that up and start calculating. And a lot of what we're going to do with patient is sometimes just clinical judgment.
And when you, like, in the hospitals that are using that for like their rapid response trigger teams, do they know how they, like, what was on that score triggering that rapid response? What was scoring them high enough? Or are they getting to the rapid and just, again, trying to use their clinical judgment during that?
I think they do know what score pops up. They also know what is triggering it. So, for example, if somebody has a low blood pressure or a high heart rate, that's usually on the dashboard that's using it. So, yes. Again, it doesn't necessarily mean that you have a high Muse score, that you definitely need. Again, these are not 100% specific. So you might come to a patient's bedside and figure out, well, actually, they just need a little bit of stabilization or a little bit of extra attention, but they're fine otherwise. So that may happen as well.
Yeah, I think it's just an interesting topic. So I just wanted to highlight that, Moni and I sort of wanted to do this case as someone who is already on the floor, because I do think when they're coming out of the ER, that's usually fresher in your mind that they could be septic. But like you said, there's just so many different things on the differential once they're on the floor. And sometimes I think that your medicine brain overtakes and you're just like, oh my gosh, it could be 18 different things. And you're trying to just justify, could it be that other thing? So I do find some of these using Muse and Muse for the dashboards is a super interesting modality for some of these hospitals. So we can go ahead and move on a little bit. So we've established, she definitely seems septic, concerned about maybe this coming from her leg because of the prior history. We'll assume that, used, your good doctor ICU voice and got some good crowd control in the room. And now you're starting to think, okay, what other diagnostic tests could be helpful for me to kind of make the next steps for this patient. So what are some of those and what do you prioritize?
So just going back to your point about patients on the floor versus patients in the ED, I think, that sense of urgency about sepsis, I think it's a little missed on the floor. So I think if you are thinking about somebody who potentially has sepsis, so definitely your stuff that you would do for in the ER. So get blood cultures, get a lactic acid, and if it's elevated, that is something that we're going to trend later. Specifically for this patient, I'm a little concerned about the report of the rash on the upper thigh. Certainly could be related just to her surgical site, but I think as an ICU doctor, I think about high mortality things. So things like neck fash or necrotizing fasciitis come first to my brain, and those are surgical emergencies. And certainly, while this patient may look just run-the-mill sepsis right now, she could go into septic shock and just go down very quickly. And so getting a surgical evaluation on her as quickly as possible. I know some people would like to send her for a CAT scan, but I think her blood pressure is a little bit low, and I'd like to stabilize that a little bit further. And sometimes necrotizing fasciitis is just a clinical diagnosis, and you don't always need an imaging. So just want to emphasize that sometimes they just need to take the patient to the OR once they've stabilized the patient. So I think for now, I'll start with that. And then, you can repeat labs, assuming she got labs that morning at 5:00, stick, maybe. And if this is late in the afternoon, sending your regular labs, CBC, chemistry would be helpful as well.
And then one of the things I had seen in the guidelines that I was just kind of confused by was procalcitonin, because I feel like procals are like thrown out the window. But the way it's like phrased in the guidelines, it almost makes me think you should trend it as if it was like a lactate, like as an inflammatory marker. But I wouldn't think about that for like Miss Suarez, who, I'm concerned about neck fash in her too.
So I think you're referring to the surviving sepsis guidelines, perhaps. So I think the recommendation, the way it's worded is they recommend against using it to decide antibiotics. So in a patient that you think has sepsis, don't use procalcitonin to guide whether or not you're going to give them antibiotics. And I think I agree with that. I don't think procalcitonin helps me decide whether or not somebody has infection or just plain inflammation. The best evidence for procalcitonin comes from lower respiratory infections and guiding antibiotic therapy. So as in you have somebody with pneumonia, procalcitonin was elevated, and if you're trying to decide when to de-escalate or stop antibiotics, the procalcitonin trend can help you with that. But I think in this particular case, I would not wait for a procalcitonin, especially at my institution. It actually takes time to come back, and that's too late. Antibiotics need to go in as soon as possible, and certainly within an hour based on the guidelines. So I wouldn't wait for that.
And then for her, you sort of already referenced this when we were talking about her specifically for the neck fash and not necessarily needing imaging to like make your clinical decision. But I think one of the things that I often see in rapids or even in codes is like someone comes in with an ultrasound to do some sort of POCUS. And I'm just curious, is like in thinking about anyone who potentially has sepsis, is there like utility to like POCUS in that moment? Or is it like more useful at other times or things like that?
I think, if there is an unclear etiology of shock and you're trying to make a decision about fluid resuscitation, perhaps, in that case, sometimes POCUS can be helpful. In this case, this looks like somebody who's septic and is now hypotensive. I think our next step is going to be giving her fluids. So I'm not exactly. I don't think in this case it'd be that helpful. And even in cases of undifferentiated shock, POCUS is not, perfect. It depends on the individual's ability to do a POCUS, and especially when it comes to your cardiac windows. And just to remind people that, it's better to use dynamic measures of fluid responsiveness. And dynamic, I mean, things that change. So POCUS can sometimes be a very static measure just in that moment, what it looks like. And you may find somebody who has an EF that's reduced and maybe have some B lines on their lung exam that may indicate some pulmonary edema, but that doesn't necessarily mean that you should withhold fluids from them. So fluid responsiveness is a much different analysis, and honestly, the best evidence if you're trying to decide if somebody's fluid down, the best evidence we probably have is the straight leg raise, which requires an art line and some other devices probably, and that's best done in the ICU. So for in that moment, POCUS may not be very helpful, especially when you're trying to just triage the patient in rapid response.
Yeah, as you're talking about this, I'm also just thinking about the logistics of bringing in the POCUS. I know that there's like the pocket ones, but still, like when you're trying to get labs and that sort of thing, what I'm hearing from you is like, if you have maybe a second and other things have already started cooking, like maybe you can stick a probe on them. But those other things we talked about, like getting the lactic acid and getting, some other labs, blood cultures, and maybe some other things started, maybe are a slightly higher priority. Is that fair?
Yeah, I agree. Especially like giving antibiotics and fluids. Like, I think I would not wait to do that, because by the time you make that decision, it's still going to take a minute for those things to come up and for the nurse to hang those. And so that's when minutes start adding up into hours.
That's a good segue, Mohleen, I think, in advancing Miss Suarez's case. So she's clearly sick. We've gone through our considerations with testing, we've got some labs cooking, and you mentioned, antibiotics and fluids. But before we can even do that, can we talk a little bit about like access, like what kind of access, how big does the needle need to be, where should it be, and that kind of thing?
So I think a good peripheral IV, the smallest gauge you can get in would be better for fluid resuscitation. So I think sometimes people jump towards central lines in certain cases. I would advise you not to do that. So when we're trying to resuscitate patients, the best flow that we get is from the shortest and fattest IV you can find, preferably above the AC. And the reason for that is if we need to start pressors, that is a safer way to do it. That'll be great. Now, if a patient is a difficult stick and has no access because they lost it or whatever reason, certainly IO is an acceptable way to give medications and fluids. But I would still have somebody, it's not as fast. So I would still have, your best nurse on the floor or your best ICU nurse try for an IV in the arm above the AC.
Okay. And you kind of alluded to, like, especially in the situation where the patient maybe isn't quite septic, but they're on their way, antibiotics are kind of prioritized. And so can we talk a little bit about what antibiotics to pick specifically? And then we can kind of ask some other stuff.
While we're still trying to work up where the sepsis is coming from, it's better to be broad and give broad coverage, and then you can always de-escalate later on. In not just in this patient, but in most patients, especially one that's been in the hospital for a while, you want to try to see if they need MRSA coverage. So, if they've had MRSA before, or if your hospital tests for MRSA colonization. So in my ICU, all patients get a MRSA NAIR swab that tests for MRSA PCR. So if they're colonized with it, probably a good reason to give MRSA coverage, so vancomycin. If they've had antibiotics recently, so she was being treated with antibiotics already, definitely in her case, because she's got a questionable skin infection, I think for her, definitely MRSA coverage is required. And then, people in the hospital who may be dialysis patients, have chronic Foleys, or have permacats, or, if they've been in and out of the hospital in the last 3 or 4 months. And depending, again, on how sick a patient is, it's better to go broad. So MRSA coverage is one. I would give vancomycin. That should give you your gram-positive coverage. And then other antibiotic choice would, if they have risk factors for Pseudomonas, that'll be another thing that I would go after. So whether you pick Zosyn, which is, the lovely combo that a lot of patients get is vancomycin and Zosyn, or you can try for another Pseudomonal coverage. There are cases where we'll give double Pseudomonal coverage depending on how sick the patient is. And there are guidelines for that, but I think those are the two to start with. And then for surgical patients especially, I keep in mind fungal coverage, especially if they've had abdominal surgeries and we're getting things like TPN. That's something else. There is something called a Candida score, not in the guidelines. This is my own personal preference. I do calculate it on patients and think about it at some point. Maybe it's not the first thing that you think about when you're thinking about your antimicrobial coverage, but definitely something on my mind that I might give. So, but if you're just deciding in that first hour, vanc Zosyn, vanc cefepime, something like that should be good.
And this is a frequent scenario where access is limited. And so you can't hang all of these at once. So is there one of the, like Piptazo or Vanc, does one of them get preference? Say you only have one access site and your nurses are trying to get, but this actually comes up. So I was just curious if there's a method to thinking through that. I mean,
if you know sort of what the patient may have, Zosyn will have some gram-positive coverage too. It will, just because it has piperacillin in it. But if you're specifically thinking about MRSA, which in this lady with skin infection, I am, I think I'd prioritize those. Also, like, I know a lot of hospitals do slow infusion of Zosyn. This is not the time for slow infusions. And just another thing for vancomycin, you want to go ahead and give a loading dose. So not just the regular maintenance dose. You want to give a loading dose of 15 to 20 milligrams per kilogram weight-based dosing. So I think in her case, I might prioritize vancomycin if I cannot get another access.
Yeah, I mean, I think we painted like a picture for her where like the MRSA coverage ends up being like very top of mind. So I agree with that sentiment. I think the big talk or whatever after SHM this year was prioritizing beta lactams especially if you don't know the source of the infection. So, which you just said too. And then it sounds like after all of that, for her, like where you are maybe thinking about a surgical site, then after that, your fungal coverage would kind of be like the third thing to go in. Is that right?
Yeah. I mean, antifungals is something more like when she's maybe down in the ICU and, you're thinking more detail. But if you're just thinking about first thing to give, agreed, beta lactams cover most gram positives and gram negative coverage. So it'll give you broad enough and it'll work for it in a case where you don't know where, things are going. So I think give that first and then vancomycin followed by that. And then if still you've had time and you've hopefully gotten some results back, you have a little bit more time, then think about antifungals.
And you mentioned double coverage, but I might have missed specific indications for double coverage.
So in my practice, if somebody has septic shock, which is often the reason they end up in the ICU, and I think they have a gram-negative rod infection, and sometimes it's clear from the get-go. Usually I find that patients who are bacteremic with gram-negative rods tend to get sick very, very quickly. So you often have somebody who maybe has a urinary source, you are already suspecting it, it. Maybe they have pyelonephritis, and you're thinking already along those lines, and they're just very, very sick. So I may give them something like a Zosyn, but then add another agent just because of how sick they are, and they'll need that coverage. Just maybe one dose. And so I know this is going to horrify some of the nephrologists on the call, perhaps, but something like a gentamicin has been used before. I know people are like worried about kidneys, but hey, bad sepsis and bad septic shock also kills kidneys. So you have to weigh risk and benefits.
It's been a while since we've mentioned that my brother's a nephrologist, and we'd be distraught by this conversation. So I think we covered antimicrobials pretty well. So I think naturally we should talk about fluids. So how much and then what kind of fluids? I know that change happened between the 2016 and 21 guidelines, I think, in terms of the recommendation of what fluids to give. So like how much and what do we give?
So the current guidelines recommend 30 cc's per kg of fluid within the first. So this is one of those Medicare sepsis criterias that you get judged on. So have to give that 30 cc's per kg fluid within 3 hours for sepsis-induced hypoperfusion, or if you think somebody has septic shock. And just to remind people, septic shock, according to the new guidelines, is if they are still hypotensive, requiring vasopressors and lactate greater than 2 after adequate fluid resuscitation. So if you're still, in that phase where you're trying to get the initial bolus of fluids, you may want to wait and see how they respond to that. There's still weak evidence for how much fluid to give. That is always a question of debate, and I'll come back to this, but what kind of fluid to give? I think there's been a move towards more balanced fluids, so crystalloids, low quality data in some case. So there was a SMART trial that came out in 2018, single center study, looked at, and it showed that there was lower mortality in those receiving balanced fluids versus normal saline. I think if you have the opportunity to give a lactated ringers or a plasma-lyte, then go ahead and give that. But if the only fluid you have around you is normal saline, go ahead and give that. I think maintaining blood pressure is more important. But if you can give balanced crystalloids, that should be given. The other thing that sometimes comes up is albumin, especially for patients who are perhaps chronically ill, have low albumin, or are perhaps patients with liver disease, liver failure. It will initially, theoretically, there's the sense that it'll maintain oncotic pressure better than crystalloids, but it is very costly. And in a routine situation, there's no clear benefit. So the guidelines say if somebody's receiving large amount of fluids, then you may consider it. But I would say, especially now with more and more move towards not giving excessive fluid resuscitation, I would rather just start vasopressors sooner than keep giving patient, more and more boluses. Give that initial 30 cc's, then reevaluate. Maybe this is the time to focus the patient and see if they may need additional fluids. I would still say best evidence is for a straight leg raise if your bed allows you to do that, and see if they're fluid responsive and give them additional fluids. But I would definitely recommend starting vasopressors earlier rather than later. And the more you fluid overload, at some point, the patient may end up in trouble.
So this is, I think, the $1 million question for every hospitalist. So at what point do you feel like they have received X amount of fluids, and so what is X, that you feel like that was adequate, like fluid test, and now I need to start like pressor support?
So if somebody's received their 30 cc's per kg, and they're still hypertensive, maybe they improved for 30 minutes, and now they're back down to where they were. I usually would favor starting, the vasopressor earlier rather than later. There is a recent trial that came out this year in New England Journal of Medicine. It's called a Clovers trial. And it showed that restrictive fluid strategy did not, which was their hypothesis, was that it would lower mortality compared to liberal fluid strategy. So patients with sepsis-induced hypotension, which is where our patient is right now, we don't know if she's in essentially shock yet, but she's definitely got hypotension, who were refractory to the initial 1 to 3 liters of fluids. They were given vasopressors with rescue fluids, or they were given 1 to 2 liters of IV boluses after that initial fluid resuscitation. So as you can see, like if somebody's received 1 to 2 liters of fluid as that initial fluid resuscitation and they're still hypotensive, I would, go ahead and consider starting vasopressors. And you can still reassess. You can still give more fluids along with the vasopressors and hopefully wean off those vasopressors if you think they're still hypovolemic.
Well, Meredith, I think it's time to recap because I feel like we just covered a lot of ground. So I'm going to do everyone a favor and do a recap. So one of the things I liked that we started with was sort of managing the room and making sure that everyone that's in the room needs to be there. So, probably about 3 nurses, and including like a charge nurse who can kind of just get things that are not in the room and helping with access and things like that, and assigning those tasks. And then it's helpful to know, the highest yield things that you want to send off to the lab when you're drawing blood would be like a blood culture and blood cultures and lactic acid. And then obviously you're starting antibiotics and fluids, and in the fluid space with the Clovers trial, restrictive versus liberal fluid strategy didn't really seem to have much difference. And yeah, I think that's a good recap of what we just did. So I think you can advance the case.
Sounds good. So Miss S, she received 3 liters of fluids and got started on her broad spectrum antimicrobial therapy. But she's still tachycardic. Her blood pressures are still on the low side. And we kind of were already referencing this before, but pressors on the floor kind of while you're triaging the situation, I think especially patient is still physically on the floor, kind of what is the practice habit or what could we think about for pressor support on the floor when you might only have that peripheral access?
So I think, depends again on your institution. So, you may be in a very resource limited hospital in the sense that an ICU room may not be readily available to you. So you may have to actually, not just during that triage time, but actually have that patient on the floor with rapid response nurse managing the patient and doing ICU level of care in the floor. So that is certainly happens at a lot of hospitals. I also think it's important to point out that even if you have an ICU room available, readily available, you want to make sure that the patient's stable before you put them in the elevator on a long trek, because it has happened where patients have arrested during transfer or have arrested immediately on arrival to the ICU. So do your due diligence, make sure they got their fluids, and if they're still hypotensive, go ahead and start them on vasopressors. The recommendation is you can certainly start them peripherally, and again, as I said, peripheral IV above the AC is safe enough. In fact, the Clovers trial that we had mentioned earlier, while this was not the primary endpoint that they looked at, but that trial also allowed for initial vasopressor use through peripheral catheters, and out of 500 patients who received vasopressors through peripheral IV, there were only 2 occurrences of extravasation, which I think is like maybe they just have great IV placing nurses at these sites, but it was a multi-center study, so I really like the fact that, the risk of extravasation, which is what we worry about the most with vasopressors, was pretty low. And then additionally, about 360 something patients out of the total 1,500 something patients that they had in the trial, only 360 got central lines. Perhaps about 200 something patients who got pressors didn't even require central lines during their stay. So I think lack of a central line should not limit vasopressor use, especially if there is going to be a delay in getting the central line in and, getting the patient to the ICU. I would go ahead and just start it. And the first line choice, of course, is norepinephrine. That is the recommended. It works, and I think it's a good choice also in not just in septic shock, but also when you have undifferentiated shock, where you might think there's some cardiac dysfunction going on, or maybe some maybe it may be cardiogenic shock. Levofed is still a good first-line pressor.
And what dose do you start?
This is where your ICU nurse comes in really handy, because I assume that most of the nurses don't have, most of the floors will not have Levofed in their Pyxis system. So if your pharmacy system works well and you can get a tube there, fantastic. If not, I sometimes call down the ICU and have them send me Levofed, norepinephrine up to the floor where I'm at, and my ICU nurse will start it. At most institutions, it should be based on the patient's weight, so you can add it. You can start it at 0.02. It just depends on how septic they are, and but you need to make sure they're in a setting where you're monitoring their vitals, and somebody is able to titrate up or titrate down, for that matter. You don't want the patient too hypertensive either, so just start it. And our ICU nurses can also mix Levofed very quickly, so they don't need to wait for pharmacy for that to happen.
Yeah, this was all very helpful, but I'm just going to say, in med school, they made it seem like if I even looked at a patient with a bag of norepi with their peripheral in mind, that they would necrose off their limbs. So this is very helpful information.
I mean, I will say in practice, this trial is great because I think it validated what we do in practice in the ICU all the time. So when patients come in, yes, we're very good at putting in central lines, and I love putting in central lines. I have fellows who love putting in central lines, but sometimes we have other priorities. We have other sick patients too. So you may not be getting that central line right as you hit the door in the ICU. Other things may need to happen. And if the patient's hypotensive, they will get Levofed peripherally, or norepinephrine, peripherally, for a good bit of time before we'll get that central line in. And sometimes, they may need norepinephrine very transiently. You may actually, if the antibiotics finally kick in, you have good source control, for example, they may be able to wean off those pressors completely. So you may, and I think that's what happens in regular cases where you may not end up reading a central line at all. So I think we use it a lot. Now, if there is a IV in the foot, that is probably not my preference to start vasopressors on. Certainly, we've done it with IOs, but I would say, again, get a good IV above the AC, not a foot IV or one in your hand. Those, I think, are more likely to extravasate and cause problems.
That was my other question, so you can give it through the IO too, if that's the access you have.
If that's the only access you have, especially in cases where, the patient has coded, I have given, you push epi through it, and that's a much bigger dose in the bolus one. You can give it, assuming at that time. IO is not my preference. It's not the same as when I'm giving vasopressors through an IV in the arm. During this time, I would prioritize that central line to get better access, because that IO can only deliver so much. So if you need fluids, you need pressors, you need antibiotics, you need more lumens. So that's the time that if we cannot get any other access, I am prioritizing a central line in that case.
And my last question on the pressors is like patients on the floor, I'm the hospitalist, I have access to an ICU. Is norepi really going to be the only one that I would consider starting, or is there any scenario where you would be using a different pressor for
So
sepsis?
if you cannot get norepinephrine up to you as quickly as you want, start whatever pressor you can start. So in my cord carts in our hospital system, we have something called dopamine, which was widely used back in the 1980s. We have moved on since then, but that's what's available. So if we need to start something right that minute and we cannot wait for the Levophed or norepinephrine to come up to the floor, just start and hang that and get the blood pressure up. You can switch it out once you have the Levophed available. The other scenario, same thing with epinephrine. If sometimes we can just mix an epinephrine drip. So if that's what's available to you, go ahead and hang it, especially if you have your friendly anesthesiologist anywhere close by. They're excellent at mixing it up. But also your ICU nurse should be able to mix up a lot of these strips because they do it on a regular basis. So whatever you can get your hand on, just go ahead and start it. And then we can always switch it out to norepinephrine when we have it available or they're down in the ICU.
This stresses me out. I feel like I would be calling you like all the time, being like, what am I allowed to do and not allowed to do? Because just like Moni said, like, I'm just the same ischemic, like necrotic, like arm is going to fall off, and it's going to be because I started the random bag of like dopamine.
Oh man, dopamine. That really is a throwback. I remember that was the one you just kind of sprinkled on at the end. Even when I was training, which was a long time ago.
Yeah.
I mean, we do use dopamine if somebody has right heart failure. So somebody with pulmonary hypertension and floor right heart failure, dopamine is something that we will preferentially use sometimes. But in most settings, if patient's blood pressure is low, you've given them fluids, you're giving them more, but they clearly need vasopressor, start whatever you have peripherally, hopefully with good access. And again, happy to come in and put in a central line if you think, hey, we don't have enough access. We have this one IO and I don't want to keep using it. Happy to come in and put in a central line and take care of the patient. And hopefully by the time you're starting pressors, the ICU is already on board and coming over to evaluate the patient if they haven't already.
Yeah, I think that's kind of the key point too, is like at this point you should be having like all of your critical care support kind of jointly making those decisions with you.
Agreed.
Yeah, because they're probably en route or borderline about to move, like you said, once they're stabilized. So you're sort of in the process of like the transfer of care anyway. So I think with that, the next set of things we're going to talk about is like all of the supportive measures that we should be doing kind of concomitantly that we don't always think about. So O2, so Miss S doesn't have a primary lung thing that we're worried about, but are there any specific like O2 requirements we should be trying to meet, or is it just kind of the same as if anything else was going on?
So far, no great trial data or evidence to guide this if what your O2 goals should be in sepsis. I also want to point out that be careful about what your monitor is reading on the pulse ox on your monitors, because if these patients are hypotensive, they clearly have poor perfusion, that pulse ox may not be capturing it, especially on the floors, unless you have devices that we use in the ICU, such as forehead monitors or more of your ear ones that get plugged in. They may be a little bit better, but sometimes if the patient is truly in bad shock, you may not get anything, and then you're relying, hopefully getting them better perfusion and getting better numbers. So just that's one caveat. there's no evidence. So I say for most acutely ill patients, you can target anything above 92%, greater or equal to 92%. If they have a pulmonary issue and let's say ARDS, then 88% is the threshold that we look for at the very least.
And then in situations where, maybe they're in acute hypoxic respiratory failure, obviously not this patient, but I remember reading that, and I don't think I'd realized this or remembered it if it was taught to me, but it seems like high flow, like this is obviously, we're hopefully transitioning to the ICU, but it seems like high flow nasal cannula is preferred over non-invasive. Did I read that wrong?
So again, depends on the situation. So I think if you're thinking about ARDS, yes, high flow nasal cannula. So, and when I talk about high flow as a pulmonologist, I'm talking about things, and I'm going to reference some devices that are brand name like Airvo or Vapotherm in some instances. So these are like very high flows. So I'm talking 50 liters per minute flows, and you can give almost 100% FiO2 through those. So those are good adjuncts for giving good amount of oxygen in somebody who's very, very hypoxic. But they don't have a lot of PEEP or, for really patients who are really hypoxic, and they may require a little bit more alveoli to be open at all times. You want that PEEP to be delivered. Of course, positive pressure ventilation is one way of doing it, whether you do it through your CPAP or BPAP, or you do it through invasive mechanical ventilation. But high flow oxygen cannulas don't give that. So if you have somebody who is going the ARDS route, you can try high flow nasal cannula first. It's just a lot more comfortable for patient. But then if they're not doing well with that, or if their work of breathing is really excessive, maybe try a non-invasive first. And then, of course, if somebody has pulmonary edema and or in any sort of cardiac etiology that might be causing pulmonary edema, then, a non-invasive in that case, I think would be more useful compared to a high flow nasal cannula, just to push that fluid out.
Yeah, I feel like my comfort with high flow was at its all-time high on the floor during COVID and has since waned.
We used it a lot. And those were, I think, good patients to have them on because they didn't necessarily require a lot of positive pressure at that point. They just required they were just very hypoxic. And so it came in really handy to have that. And this is segueing into a different topic, but ARDS at some point, I think they're going to revise their definition, hopefully, and take this into account, because currently the definition requires you to have a PEEP of greater than equal to 5 to call something ARDS. But clearly, I think there's some debate about that.
Okay. I think we've covered floor level oxygenation about as well as we should. So this next part's kind of the smorgasbord, as I like to call it. There's a whole litany of things that get brought up in sepsis, some of which I recall using, some of which have come and gone in vogue and whatnot. So steroids, that one I think still probably has some utilization, but in the acute, rapid situation, how useful are steroids?
So I think on a floor, probably not the first thing that's coming to my mind, unless you tell me that this is somebody who has adrenal insufficiency diagnosed already, and which is very few and far in between cases. So unless that's the case and you know this about the patient, steroids are not something that I'm thinking on the floor. Certainly in the ICU, that is something that we do use. Now, they have been shown to accelerate resolution of shock, but clearly has no effect on mortality. And then, there are some side effects associated to it. So steroids do cause neuromuscular weakness in the long run. So we typically reserve it when the guidelines recommend if you are on a norepinephrine dose of greater than to 5 micrograms per kg per minute. So if you're at that level of Levophed, you should consider adding steroids. And this is also the time that I'm considering adding a second pressor, which is usually vasopressin. So if I'm adding a second pressor around that time, I will probably go ahead and put them on stress dose steroids, which my preference has been hydrocortisone 50 every 6 hours. There are other steroid formulations that have been used and steroid infusions that have been used. Again, no effect on mortality, so that's why it's not as prioritized, but certainly something that I think about in patients who have severe, very bad shock and are requiring more than one pressor.
So some of the things that go with steroids, obviously stress ulcer prophylaxis, and then glucose control is probably very relevant. So I think we can sort of remember that, and hopefully they're in the ICU when this is happening. So I'm really not thinking about it. And then, with sepsis and, always thinking about VTE risk. So making sure there's prophylaxis for that. A couple of my fan favorites, honestly, vitamin C. How do we feel about that? High dose vitamin C.
Yeah, I know. Back when we were giving people vitamin C like crazy. So, we were, my institution was a part of the Victus trial. And that is the randomized control trial that studied vitamin C along with thiamine and hydrocortisone compared with placebo. And it actually did not show any mortality benefit. And it was actually terminated early for administrative reasons and may have been underpowered, but really did not show any benefit. And the surviving sepsis guidelines recommend against it. So they recommended against it even before the trial results were out. But the quality of evidence prior to that was pretty low evidence. But now we have this trial that came out. So it's really fallen out of favor. And I can't remember the last time I gave somebody vitamin C. Also, fun fact, if you give somebody vitamin C, you cannot use AccuChecks or glucometer checks for checking their glucose levels. It's incorrect. So you need to actually draw it on patients. So it also adds a logistical hurdle for patients, patient care.
I did not know that.
Is that over because you're giving them a certain dose?
Yeah. So
of vitamin C?
I do not recall if it's dose related, but certainly when we were doing the trial, those patients could not just get regular AccuChecks. So, if they have an art line or whatever access they have, we were checking blood through that.
Yeah. And I think, enteral nutrition also is something we think about. And then the high dose vitamin C actually is like a nice segue into just very briefly AKI management. And then, the utilization or need for bicarb or not, because, the AKI is resultant from the high dose vitamin C.
I will say that, probably, they will have some pre-renal etiology if they were a little bit hypovolemic, but if they were also in septic shock, they probably are going to progress to something called ATN. Normally, in the immediate setting, so on the floor, they're not going to be acidotic because of septic or septic shock resulting in AKI right that minute. They don't become that acidotic from that right away. What I do see happen is if they have respiratory reasons. So, somebody who's in profound septic shock, completely obtunded, cannot protect their airway, their PCO2 may climb up to 100 and then their pH is like 7.0. So if that's the scenario, which often does happen. So if you walk into a room, somebody's floridly septic, you've given them fluids, you've hung the vasopressors, and they need to be intubated. So yes, you can intubate them, but realize that they're probably profoundly acidotic. And in that case, before you start that trek to the ICU, I may sometimes we'll draw an ABG and get that very quickly. There are POCT available ABG to tell you exactly what their pH is. And then I may give a push of bicarb just to stabilize them. And hopefully, if they've been intubated, that PCO2 will go away and their pH will get stabilized. But as they do get into AKI, they will slowly, and if it does not get better, start to have electrolyte disturbances or acidosis, especially if they're in really bad shape. And then that's the case, bicarb pushes for immediate stabilization. But if they're really acidotic, I tend to go for renal replacement therapy. So this is when we're putting in another catheter and going for dialysis. You can do bicarb drips. Those are usually for temporizing measures. You're giving a lot of fluid to somebody. And so I don't wait. Like if somebody's really going bad, I prefer to talk to my nephrologist early and start them thinking about dialysis early and just, hang that bicarb while I'm trying to get the line in, get continuous renal replacement started. Those things take some time. So hopefully you're temporizing things with it. But if they really need dialysis, and they need dialysis, and you should do that early.
Any other smorgasbord you want to talk about?
No, I think that's good.
Okay. Just kind of bringing it home. We know these patients are very sick. So I think it's, important to think about two things, prognosis and then the utility of palliative care. I think those are two that I think good to a note to end on.
Yeah. So, if somebody has septic shock, the mortality for that in a lot of studies is upwards of 40%. So, that is a bad prognosis for a lot of patients. And, oftentimes the areas that I see that we can do better on the floors are patients that are not going to do well in the long run from the moment that they were admitted to the hospital. So these are chronic nursing home patients or patients who are very elderly with multiple comorbidities who've been in and out of the hospital or are bedbound. And just, that they're not going to do very well. And so while they may have, or if they've been maybe they came in doing somewhat okay, but now due to various complications have had a prolonged hospital course, they may be doing okay for now, awaiting placement. But as it often happens, just the day before they're supposed to go out and get discharged, they get septic and require transfer to the ICU at that point. So I think getting palliative care involved and having those goals of care discussions early, knowing that if a complication like this happens, they're not going to do very well in the long run, and having those conversations early and having that documented, especially with family, is very important, because the time that they're crashing or somebody's having a rapid called on the floor, those are really not ideal situations where we want to be having those conversations. I mean, we do have those conversations, don't get me wrong. Sometimes, while we're doing all of the things that we've talked about, somebody's also calling the family and trying to have these discussions and trying to decide. But sometimes we can't wait, for the family to get on the phone, and we just need to do so. Like if somebody needs to be intubated and they're full code from everything else that we've read, then I'm going to go ahead and do that. So, I think in that case, I think those are areas where I feel that hospitalists, I know you guys are very busy on the floor, you have tons of patients, and maybe there's some comfort in having seen that patient every day and knowing that they're doing okay, but just having it on the back of the mind that, if they're sick enough to be in the hospital, they are sick enough to get a complication and end up in the ICU. And maybe that's not the best place for them, because that 40% is an average mortality risk for somebody who's elderly and has a whole bunch of comorbidities. That risk is probably much higher.
This whole episode, we were kind of painting like a rapid response situation. I think when you call the family and you update them in that moment that, patient's not doing well, it's a lot for them to take in and for them to adjust to the rate that you're having to make decisions. It's really difficult for the families to make any of those decisions in the time frame that you really need it. So I wholeheartedly agree that like the earlier the conversations happen in the hospital course, it just sets everyone up for more success later, to really know what the patient and the family's goals are.
Yeah. And, the other situation that I also come across not so infrequently is where the hospital has done the greatest job and had this conversation, and patient and family were aware, and there's great documentation that they do not want to be resuscitated, and would not want to be intubated. But then when a rapid gets called, somebody calls the family, and now the family says, no, we want everything done. And so there's that rapid reversal. And hopefully the conversation is great enough, but this still happens. And in that case, you do the best that you can. And so certainly it has happened where we've done everything, and then when we've talked to the family again after they've had a chance to come in and, see the patient. And sometimes all people want is to see their loved one once before they expire. And I also like to warn people that while we may continue to do everything that we can to treat their underlying issue, to keep their heart going, as people like to call it, but it's no guarantee that they're not going to arrest in the near future. And so while we try to give families every opportunity to come say that final goodbye, which is very important for patients, family members, sometimes it's just not possible. And so there is great training from various societies about how to have these conversations, especially in a setting like a rapidly evolving setting. But a lot of it is practice, and a lot of it is also experience. It's just knowing what things are important at any given time. So sometimes if a patient's really sick, you prioritize treating them, and then while conversations with family continue.
So I think that's a good place for us to not keep you here all night talking about this. So do you have any take-home points, Mohleen, for the audience that you want to make sure they took away from the episode?
On the floors, keep your eyes and ears open towards patients developing sepsis. Identify that early. And once you have that suspicion, go ahead and give your antibiotics early. I think that's one of these. If there's one thing you take away from this entire talk, it is try to get those antibiotics in the first hour as soon as you can. Don't wait for your test results to guide your antibiotic administration. And then fluids, go ahead and get them started. Don't be afraid of vasopressors. You can start them peripherally. You have my blessing with backup from evidence from latest trials about the safety of doing that. And then, call your friendly ICU intensivist. We're available and happy to help and take that care of that patient over.
Awesome. And anything you want to plug?
I know this is a slog to go through these guidelines that we just mentioned, but I think it's worth every once in a while to go through them and read them, and keep your eye out for all the things that we keep changing every once in a while. But there are certainly, for folks who are in higher admin positions, some of these guidelines are important criteria from Medicare perspective. So they're worth knowing to make sure that you on the floor are carrying it. So even if you get a patient from the ED, making sure you're trending that lactate and things of that nature that are important. So it's worth a glance. At least read the highlighted recommendations. You don't have to read the entire evidence behind it.
Great. Thanks, Mohleen.
Thank you.
So this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more?
Yep.
Join our Patreon and get all episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox, including our Curbsiders Digest recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value care, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on YouTube, Spotify, or Apple Podcasts, or email us at askcurbsiders@gmail.com. As a reminder that this and most episodes are available for free CME credit for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. Special thanks to us for writing a fantastic episode. And to our whole Curbsiders team. Our technical production is done by the team at Podpaste. Elizabeth Proto runs our social media, and Stuart Brigham composed our theme music. Until next time, I've been Moni Amin.
And as always, I'm Meredith Trubit. Thank you and good night.